I think okay. It's recording. Hi, really quickly, so I don't have to move the camera. This is Eileen Harvey, and I'm going to be doing my newborn assessment, and I'm gonna just have the baby in view, so you don't need to see me. Okay, so baby has come out of the mother, and first thing we like to do is go ahead and dry off for thermal regulation. Dry off the baby and get rid of the wet towels, so that way they don't get chilled. And then, like you mentioned, we can do this assessment on directly on the mother's abdomen. Because we want to encourage skin to skin. It also helps regulate the temperature of the baby. So that would probably be the ideal thing to do. But you can also do it on a lined and protected table if you need to as well, with the rails up. Okay, so but pretend like the baby's on the mother, because that'd be best. So at this point, it's just a general observation. Is the baby vocal, crying, loud, shrill? Is it pink? Should probably expect the extremities to be a little bit blue. And then is the baby moving? Is it lethargic? We're looking for, basically, you're starting your assessment right away with what the baby is sounds like, looks like, with your APGAR scores. So, and then we do go ahead and like to get a weight. And I'm going to say for weight, we do it in pounds, because that's what, Americans go by. But obviously in the nursing and medical field, we do kilograms. So you're going to weigh the baby on the scale. And I remember them doing this when I had my children. And then they actually did the length on the scale while the baby was on the scale, using the paper tape measure. And you just have to kind of stretch their leg out so you can mark it after the leg is stretched. And of course, inches and centimeters are how it's documented. And then, like you mentioned, while you have your imaginary, my imaginary tape measure, I'm going to go ahead and get a head circumference, a chest circumference at the nipple buds, and then I'm going to go ahead and get an abdominal circumference as well. And then at this point, you can put the baby back with the mom, because you had to take it away, obviously, just to keep it warm and encourage that skin to skin bonding. So then we can go ahead and get some vitals. So we want to do heart rate, and I really like the way, you want to do a whole minute, because it is really fast. And I liked your idea of tapping, because it's really fast. Like, it's really hard to keep track of. But then also with the respirations, on keeping your hands on the chest and using your eyes and your feeling, because it's hard on adults, and I have to imagine it's even harder on a baby to get the respirations, but we want to go ahead and get both of those. And then we'll have our stethoscope, and we would go ahead and get listen to our abdomen for the bowels. And I left my stethoscope on the couch, so I'm not going to go grab it, but it's you would listen to the bowels just like you would an adult, the 4 quadrants. And like you mentioned, they should have some kind of bowel sound. They've been eating, so and then you should also listen to the assessment on the back, and you could do all 4 on the back as well. And you said it would be normal to hear kind of a wet sound, because they just came out of a wet environment, so that's normal. Nothing really to be worried about. Okay, we're going to go ahead and get an auxiliary temp. I know you mentioned that some hospitals still do a rectal temp, but it should only be once, and really I think most hospitals are trying to get away from it, at least in my experience. Assess for pain. As a mom, I do know exactly what you're talking about with the there's a different, when they're in pain, it's a different kind of cry. Now, obviously, a new mother is not going to know that, but if you are a labor delivery nurse, you probably, unless you're brand stinking new, you probably know, you've been around with babies, you know what a pained cry sounds like versus a newborn cry, just a cry. I'm hungry, I'm scared, I'm wet, stuff like that. There's different cries. So if the mom doesn't know, you should know, but the mom will eventually learn what those are. Okay, so then we're going to take a look at the skin. This baby's very white. But the skin should be, we're looking at the color, and obviously, like I mentioned, when they're first born, it should be pink in the centralized area, and the extremities can be bluish. We're just waiting on circulation to get down to there. They can be mottled if they're cold. We're looking for turgid. You're right. Their skin is like the smoothest thing ever and the softest, and I love touching it. But you're looking for texture. Lanugo, which is going to be the hair, and obviously the longer the baby was in, the less hair it's going to have. But I know mine had them both. Mostly they were full term. They had it on their backs, mostly their shoulders and back. Vernix, which is the kind of cottage cheese, white, creamy stuff that babies are born. Again, the longer they're in, the less of that they're going to have. We're looking for any rashes. Like the common ones are the Mongolian spots on their bottoms. And then stork bites. My daughter had one on her nose. So, and then we can go straight into checking reflexes at this point. And like you mentioned, even if you don't actually do this, which I've seen the snap and they should go like this, like like they get scared. You're right, they'll do that at some point. It's almost like that when you have that dream of you're falling, they're constantly doing that. But what you're looking for is symmetry. I just moved my table. If you have only one arm go up and not the other, then we'd be concerned about possibly a break in the clavicle, or some kind of injury during some kind of birth trauma. So we're going to look for a blink reflex, and then you'd have your pen light, and you can also go ahead and do the pupillary, and again, like you mentioned, it is kind of hard to assess on newborns because they do put, they're swollen, their eyes are small, and they put that erythromycin ointment on there for prophylaxis. So, but if you can, try to look at the pupillaries. They should be just like an adult, and they should reflex, and they should blink when you shine a light at them. The rooting reflex, while you're up here, if you rub their cheek, they should instinctively turn their mouth towards it, and open, which this baby's mouth doesn't open, so I can't do that. But like you mentioned, when it's open, while you're there, might as well go ahead and you can feel in the mouth for the soft and hard palate to make sure that they're completely formed. Let's see. So the palmar reflex, that's going to be when you put your, for the hands and the feet, it should be same thing. When you put your finger or thumb inside their palm, their fingers should curl over around it. Same thing with their feet. Their toes should curl around your finger. The Babinski, it's the rubbing on the side of the J shape of the foot. If you rub it, their toes should flare. Let's see. I think this is the tonic reflex. Sorry, I can't remember here. Tonic reflex. Basically, if their head is one way, their arm, like let's say I turn their head this way, their head turned this way, their arms should go out. It's kind of like a balancing mechanism. So opposite arm to where the head's pointed. And then trunk innervation. If you were to turn them over, they should, it's not really a crawl at this age, but it's kind of an inching. It's kind of like a ring. And you can also look at their butt and make sure that it's symmetrical back here. Let's see. Checking the scalp for molding. You're looking for any hematomas, especially if they were born by a vacuum birth or basically if they were born by that vacuum birth. But they also could have the caput, which is where it crosses the suture lines, or you could have a cephalohematoma where it doesn't cross it. You can have, looking at the fontanelles, make sure that they should be soft and pliable, kind of flat. They shouldn't be sunken or bulging. And then you're just looking for the scalp, and like I said, if they came out a different direction than normal, but they came out head first, it can actually, or if they came out by vacuum, it can actually cause a kind of cone head. It kind of sucks their head in. So, and then we can go and look, working down the body, we can look at our face. And again, going back to different kinds of birth methods, if they had to use forceps, you might see the marks on there around the face where the forceps were. You're looking for symmetry. Obviously, you want the eyes and both sides to be equal. You might see semilia, which are the little white bumps. Those are completely normal. You don't want to pick at them. You're going to look at their nose, and then you want to plug each side of the nose to make sure that they can breathe out of both sides of the nares. You're going to check their ears, and depending on the gestation age, if they're full term, their ears should be just like ours. If you pull them forward, they should pop right back. Obviously, if they're preterm, they're not. They could actually stay folded forward. But you're just looking also for full development of the medius. You want to make sure that the ear membranes and everything inside have been, or they look how an ear should look. It's just smaller. Let's see. We're gonna look at the mouth, and we've already checked the platelet, and then you can also, while you're in there, you could have checked the tongue, and what you're looking for is A, obviously full development, and then B, the part that attaches the tongue to the bottom of the mouth. It sometimes is like it's connected too far out, and so that's my daughter. And so it makes it hard to for them to feed because the tongue doesn't come out as far as a normal tongue should. So that's something that can be fixed if that's found. Yes, my dog. What do you need? Okay, I'm sorry, you cut yourself. I'll be there in a minute, okay? Okay, so we would do a hearing test. Every baby gets a hearing test, and then but the first one you can do at this moment is just, do they react to sounds? And like you mentioned, they've been hearing their mother's voice for 9 months. They should be able to kind of look over towards where the sound is. They'll recognize the voices they've been hearing for the last 9 months, so whoever that might be. And then while you're I meant to mention that the eyes, you can check the eyes. You can look for check the sclera. Really what you're looking for is any kind of yellowing that could be an indication of the pathological jaundice, which is the one we're worried about. But also you can look at the conjunctiva, and then obviously symmetry. And you've already checked your pupillary response, and you've already checked your, at this point, you've already checked your blink response. So moving down, you can check their neck. It should be freely movable. And then checking the clavicles, and obviously if you've already done the more reflex, you should be able to see, but you can also just by pressing on them, the clavicles, you should be able to feel if it has some kind of break, you'll feel a small bump, or it'll be slightly uneven. Checking for the chest just by looking, are they breathing easily? Are they having retractions? Are there any kind of the little grunts that you mentioned, like that little high-pitched grunt? Those are not good. And if that's happening, we need to investigate. And then if you haven't done so, listen to the heart sounds. And you mentioned that it was normal to have a murmur in new babies. It usually goes away. So and heart rate should be I believe you said 110 to 1. It's fast. I can't remember, but it should be, it's okay if it's fast. It's faster, way faster than adults. I can't remember what the max is, but we're gonna check the abdomen. We're looking for the umbilical cord. Is it clamped? And we keep it clamped and for a few days until the artery and veins completely close. And then we're gonna. You mentioned you can also check the inguinal pulse as well, right there. Oh, I'm sorry. You can also check the pulses on the umbilical if you're having a hard time getting a pulse on the baby. You can check right there as well. It pulsates for a while after the firstborn. And then you can check the inguinal pulses as well to make sure that there is nothing wrong with their hips. Make sure that there's nothing pressing on those, pressing on that would keep blood from going there. And let's see. So extremities, we're looking for good flexion, so they should be out. Good flexion. When you have the baby over, earlier you said that the spine would be a C-shaped. That's normal for babies. We're looking for any tufts of hair or indentations. I know I saw a picture in the book, like an indentation right above the sacrum, and any tufts of hair that can actually be indicative of something else. So anything like that should just be documented. And then the genitalia in females, it is normal to have a little bit of bleeding. It should be light and it will go away. You'll look at the labia and the clitoris. The farther along they are, the less prominent the clitoris will be. And you're just looking for full development and symmetry. For boys, you're looking at the urethra at the tip of it. And then check the scrotum, make sure that the testes have descended. And again, premature babies, the testes might not be descended yet. On the rectal assessment, bowel movements will be the thick tarry meconium for the first few ones, at least the first few days, at least was for me. You want to make sure that they, for the urinary elimination pattern, 1 per day and going up 1 each day. I'm sorry, 1 the first day and then going up 1 for each day after. And after a week, it should be about 6 to 10 a day, depending on how much they eat or how much they drink. And then you want them to pee and poop before going home, so that way you can assess that that their bowels and urethra are working correctly. And then we check for jaundice, which we kind of did a little bit with the sclera. It's normal to have jaundice 24 hours after, up to 3 days. That's the normal jaundice. That's the physiological. And that will go away. And the pathological is the one that we're worried about, and that will be present within 24 hours. So we'll have to keep an eye on that. And then other than that, that should be everything I had. So that should be the end of that for the newborn assessment. And then put baby back on mommy. If baby left mommy. Thanks.